Hello, everyone. Thank you so much for joining us today for our webinar on some of the where we're going to cover some of the highlights from our Fall Cancer Policy Roundtable that we hosted last November. During the pandemic, we were able to host our policy roundtables virtually, and all of our CPAT members from across the country could attend. And now that we're back to in person, we know that people can't fly in for these events, but we had some really incredible discussions at our Fall Policy Roundtable. So we wanted to bring you some of the highlights. And we're going to cover two of the topics that we covered in our Fall Policy Roundtable today. I'm really pleased to have some excellent experts joining us today to talk about two subjects. First, we're going to start with talking about Medicare Advantage, and I'm pleased to have Dr. Tricia Neuman from Kaiser Family Foundation, or KFF, joining us. She is an expert on Medicare policy, and she's joined us for a couple of our roundtables last year, and we're really grateful for her to be here today. Before I turn it over to her, I'm just going to share, we started the roundtable with a video from Natalie Stevenson, who's a CPAT member, an Elevate ambassador, and living with stage 4 cancer. And she talked about her own experience with Medicare Advantage and some of the benefits and trade-offs of Medicare Advantage. She is on disability, so she had to choose a Medicare plan, but she wasn't able to get a supplemental Medicare plan in her state of Nevada. And so she had to choose Medicare Advantage, which means she's restricted to providers in Nevada, which is where she lives. But she received much of her care before going on Medicare from UCSF, which is a 3-hour drive from her. So right now, this is the best option for her, but she said she's concerned about what happens if her medication needs change or her, and she needs other providers that are not going to be in her network. So we're going to share, I guess we already have in the chat a link to the video that Natalie shared that really highlighted some of the benefits and trade-offs of Medicare Advantage for cancer patients. Also, we're sharing in the chat the bios so we can leave as much time for our speakers to talk rather than me reading off their bios. So I'm going to turn it over to you, Trish. Thank you so much.
Thank you so much. I am really happy to be here. I am happy to be talking about this topic. I really appreciate the work that you all do. I, live and work in the policy world, but like you, I have deep connections to the cancer community. And so I'm grateful for all the work that you do. I'm going to be talking about Medicare Advantage, and it occurs to me I might start with saying what Medicare Advantage is. This is a part of the program that is managed by private plans, private insurance companies. Medicare pays these plans to provide Medicare benefits. And if I can go, I actually can't see my slides, but if I could go to the first slide that shows the growth in enrollment, and the next slide, please. Right. What you can see here is that Medicare now, more than half of all people on Medicare, the 51% is actually 52%, are enrolled in one of these Medicare Advantage HMOs or PPOs. What that means is Medicare really looks a lot different today than what people might think when they think about Medicare for all, because half of Medicare is really engaged in a marketplace of private insurance companies that are managing their Medicare benefits. Significantly, the enrollment is projected to grow to 60% by 2030. So Medicare looks a lot different today than it did when I first started working on the program. And it also, means different things to people depending upon where they are in terms of their health care, their mental health, their physical issues, and their incomes. So let's go to the next slide, please. And apologies for speaking quickly, but we have a lot to get through and not much time. Here, what you can see is, while I was saying to you, half of all eligible people nationwide are enrolled in a Medicare Advantage plan. If you look at many cities across the country, you'll see that it's 2/3 or more of people living in those areas are enrolled in a Medicare HMO or PPO. So what that means is their experience locally is very different, and this affects the beneficiaries who are living there, the people who are living there. It's also an issue we're now learning for providers, and I will come back to that in a little bit. Can I have the next slide, please? Here you see that it's really two insurance companies, United Healthcare and Humana, that dominate this marketplace. So roughly half of all Medicare Advantage enrollees are in a plan that is administered by United Healthcare and Humana. That means these are the companies that have a lot of decision-making authority over cost sharing, premiums, extra benefits, rules pertaining to prior authorization, provider networks, and more that matter a lot for people, particularly people who are big users of the healthcare system. So people with serious conditions like cancer, like MS, and like many others. Can I have the next slide? Insurers have gravitated to this marketplace. It's been sort of a magnetic force for the insurance industry. And what you can see here is that over time, the average Medicare beneficiary has a choice of more and more plans. So in 2024, like last year, the average Medicare beneficiary had a choice of 43 Medicare Advantage plans in addition to traditional Medicare. So this matters because plans vary a lot, and it is extremely difficult for even researchers to be able to describe how they vary. And the point is, these differences matter quite a bit. So people not only choose between traditional Medicare and Medicare Advantage, but if they choose Medicare Advantage, then which plan would be best for them and how to factor in all the different ways in which they vary. So let's go to the next slide, because this gives you a feel for the different ways in which Medicare Advantage plans do vary. And if you're thinking about what this means for people with cancer, you know it matters a lot. So the first is cost sharing for Medicare covered benefits. Plans are required to provide the actuarial equivalent to Medicare benefits like hospital, physician, post-acute care, but they can vary cost sharing. This information is available on the Medicare Plan Finder, but people generally don't think about what they will need when they get sick, when they're looking for a plan, unless they already have a diagnosis. And cost sharing can really matter. Unlike traditional Medicare, people in Medicare Advantage do not buy Medigap policies. So when there's costs for an infusion drug, or when there's costs for post-acute care, or a daily copay for hospital services, that starts to build up and matter for people who need a lot of services, but it's awfully difficult to compare in advance. Plans also vary on extra benefits, which are a real draw for people because plans offer dental, vision, hearing, debit cards now for medical, over-the-counter medical stuff. We're even seeing Instacart for groceries. Those are very appealing, and they do vary. The cost sharing for these extra benefits vary. We're doing a lot of work now on the networks, provider networks. Very, very difficult to compare across plans. There's really a burden on the individual or their family to be sure that a doctor, a specialist, oncologist, an NCI cancer center, an academic medical center is in their plan. It is not easy to compare on the Plan Finder, but this obviously matters so much. I mean, I imagine many of you know people with personal stories where they wanted to go see a certain surgeon or an oncologist, but that surgeon and oncologist wasn't in their network, and they weren't able to, they'd either have to switch plans or go find somebody else. So this matters. But again, hard to see in advance. The same is true for extra benefits. People are very much drawn to dental because plans offer, say, $1,000 or $1,500 of some dental care, but it's not clear which dentists are in the network. And I would hazard to guess that the provider networks that are made available to consumers are inaccurate, because based on our study of physician networks, we're finding lots of inaccuracies and missing information. Drug coverage also varies. And here's where it's sort of interesting for Medicare Advantage, because people who are in traditional Medicare can choose their Part D plan. And there are a lot of Part D plans that are available. When you choose a Medicare Advantage plan, you get what you get. Prior authorization rules also vary, and so too do quality ratings. So for a consumer, there's a lot to sort through when choosing a plan, and these things do matter. Can I have the next slide? So why are people gravitating to Medicare Advantage? And why is enrollment growing so rapidly? The first thing I want to say is that the payment system set by law is designed to attract insurance companies across the country, and insurers and brokers have a financial incentive to enroll beneficiaries into Medicare Advantage plans. So when you so that is a driver. I'm sure you saw a slew of ads, important to keep in mind. This allows Medicare Advantage plans, these so-called overpayments, allow Medicare Advantage plans to offer extra benefits that we just talked about, like dental, that are not covered under traditional Medicare. And unlike traditional Medicare, Medicare Advantage plans are required to include an out-of-pocket limit for Medicare covered services, also a draw. Medicare Advantage is also more convenient for people. It's simpler. It's one-stop shopping. So you don't have to buy a Medigap plan or Part D plan. You choose your HMO or PPO, and that's that. And simplicity for people who are getting older or sicker is very appealing because people have a lot more to think about than their insurance. Aggressive marketing. We did a study of how plans are marketing to people in Medicare extremely aggressively, lots of TV ads, lots of incentives for brokers. Brokers get paid a lot more for selling Medicare Advantage than other Medicare products. Another reason for growth is that employers are increasingly shifting their retirees into Medicare Advantage plans to get some savings for themselves. We're also seeing increasingly that employers are not giving their retirees a choice between Medicare Advantage and some other kind of supplement. This essentially locks in their retirees to Medicare Advantage HMOs and PPOs for their core Medicare benefits, whereas historically they used to be able to have traditional Medicare with the employer supplement. This is something that Shelley mentioned. Enrollees with pre-existing conditions may feel locked into Medicare Advantage because they may not be able to purchase a Medigap policy if they have a pre-existing condition. So for people who want to disenroll from Medicare Advantage, they can, during the open enrollment period, go back to traditional Medicare. But if they have a pre-existing condition, in most states in this country, they may be denied a Medigap policy. And so that may be too big a financial risk for some people to take. And then finally, beneficiaries may be unaware of some of the trade-offs associated with Medicare Advantage. They see the ads, they see those healthy people jumping on trampolines, getting their dental benefits and say, hey, that looks pretty good to me. And they're not thinking about what they need when they get sick and whether it's the right choice for them. So that takes me to the next slide, which is what are the trade-offs that need to be thought through? Well, one is prior authorization. Medicare Advantage plans use prior authorization much more commonly, typically, than traditional Medicare, which means that patients working with their doctors or hospitals have to get prior authorization before someone can receive a service that their doctor says is needed. This creates hassles that you can hear about from doctors, but it also delays in getting needed care. And that is something that I think people don't think about when they're not using many services because they're relatively healthy. A small share of these prior authorization requests are denied, but when they are denied, they're a big deal for people who think they need the service that was denied. A very small share of denials are appealed, but interestingly, most people who appeal their denials have those denials overturned. But I think people think they're kind of powerless over an insurance company to appeal a denial. Network restrictions. I talked about this earlier, but I can tell you from my own family, this was a real issue for me with a family member who had cancer, and I wanted to be sure she could go to the best cancer specialists and hospitals in the country. With Medicare Advantage, there's also no choice of formularies. You get what you get. So that's what's different from traditional Medicare. This matters for people who are looking for specific drugs to be covered at a lower cost. Once the out-of-pocket cap phases in, the cost consideration may be less important, but certainly having a choice of medications matters a lot. And then potentially higher out-of-pocket costs. This is counterintuitive because Medicare Advantage plans do have out-of-pocket limits, unlike traditional Medicare. But what we have seen is that when you put traditional Medicare together with Medicare supplements like Medigap or even Medicaid or some retiree health plans, that people pay less for their Medicare benefits in traditional Medicare, even when premiums are taken into account, than they would with the Medicare Advantage plan with a higher out-of-pocket, with an out-of-pocket limit. So I think that is a very, very, very quick run through of the opportunities and challenges associated with Medicare Advantage for people on Medicare. But I sure do think it's important to watch what's going on here, or look for opportunities for improved transparency, because without a greater focus, Medicare Advantage will really be the Medicare program. I'd be happy to take your questions.
Thank you, Trish. I'm going to start with a couple. So one thing you talked about, somebody asked if you can switch from Medicare Advantage to traditional Medicare, and you said that you can, but you may not be able to buy a Medigap policy. Is there any move, since obviously we worked really hard with the Affordable Care Act and then in all of the efforts to overturn repeal the Affordable Care Act, to make the case that the ban on denying people because of, or that it was important not to discriminate against people because of pre-existing conditions. Is there any movement to apply that same principle to Medicare Advantage? I mean, I'm thinking about this just because one of the reasons we had this conversation and we want to continue working with you is to think about where can we, as NCCS and working with others in the cancer community, advocate for ways to make sure that Medicare Advantage does protect cancer patients. And if they want to switch, is there a way to, I mean, is there any appetite for that kind of policy to not allow Medigap plans to discriminate?
Yeah, I mean, I think it's a great question. I know that there are, we hear from congressional staff. I know there have been bills in the past to allow for guarantee issue and to not allow denials based on pre-existing conditions. I think senior advocacy groups have looked into this issue. So I think there are opportunities to collaborate with other advocacy organizations to move this forward. A related issue is why people, for people who prefer traditional Medicare, how to make it more accessible if you're concerned about the lack of an out-of-pocket cap, which Medigap really helps with. So another option, policy option, is to make sure that traditional Medicare has an out-of-pocket cap, just like Medicare Advantage. It's a little bit unusual to have a guaranteed benefit in one part of the Medicare program, but not in the other.
Yeah. And we had a couple of comments in both questions submitted before and here about network access. And I know you said you're working on a report on that, and about large health systems that are now opting out of Medicare Advantage because of the denials and prior authorization. I'm wondering, I know we'll be eagerly awaiting your report. Is there any correlation to the areas where, you show that there were 2/3 or even almost 3/4 of the Medicare population in that area has Medicare Advantage? Do they have better network access because they have the majority of patients, or is that not, there's not?
We don't know. I will look at that, but I mean, it's a really good question. What we're finding, and this is super important, is within communities, there's a wide variation. So some plans might have 70% of all physicians, while others have 25% of all physicians. The point is, if you're looking for a plan, there's no way you're going to know that. It's just not available. It's not public information.
There was a question can you just briefly describe what a Medigap plan is?
Yes, of course. These are supplemental insurance policies that are sold by the same companies that are offering Medicare Advantage, like United Healthcare through AARP, for example. These are policies sold to individuals that supplement traditional Medicare. So if you're in traditional Medicare, it helps to pay it covers your cost sharing. It covers your deductible mostly. It covers co-pays for skilled nursing facility care, 20% co-insurance for physician. It makes life a lot easier for people in traditional Medicare because it's usually seamless in that Medigap works with regular Medicare. And so often people in traditional Medicare won't have to deal with bills when they have a supplement because it happens automatically for them. So they get a lot of statements that say, this is not a bill, but Medicare pays its part, Medigap pays its part.
Okay, we have a bunch of questions, but we're not going to be able to get to all of them. But I will ask this one. Can you talk about the network limits? And again, this may be coming from your in your report, but how does it affect people in rural areas more? Because of the kind of the net markets you were showing were all cities, and what about people in rural areas?
Yeah, I mean, interestingly, and this is just preliminary data, so don't hold me to it. We're actually seeing a bigger issue in large urban areas, more so because I think for plans to exist at all in rural areas, there's not a lot of choice there in terms of providers, so they have to have them. So this may be a bigger concern in large metropolitan areas. Stay tuned for that.
Great. Thank you very much. I would love to keep discussing this, but this was our first attempt to try to cover two topics in one webinar. But
Sure.
as I mentioned, we really want to work on this issue, and that's why we are having these discussions. So I think this conversation will continue, and we'd love to continue working with you on policy options. And, we'll be looking forward to your report on the network adequacy, and we'll share that with our constituents. Maybe we can even do a follow-up webinar on that.
Terrific. Terrific. Thanks for having me, and I'd be happy to work with you.
Thank you so much. We really appreciate it. So now we're going to move on to talking about the Inflation Reduction Act. And we've had a couple of different discussions at policy roundtables about the IRA, as it's commonly referred to, and how it will affect patients in their access to medicine, in their copays, and how it might affect innovation. So we have two experts with us. Kirsten Axelsen is a senior advisor with DLA Piper, and Dr. Mariana Socal is with the Johns Hopkins School of Public Health. So I'm going to let each of them spend a few minutes talking about what they see are some of the benefits and trade-offs of the IRA, and then we'll get into Q&A. And we'll start with Kirsten.
Thank you so much for having me today. It's really an honor to be part of this very esteemed group. So considering the IRA and its implication on new drug development, I think first, it's really recognizing the incentives that are put in place with this change in law. There are sort of four key ways that drugs will be affected. One way which will increase access to medicines, which is the out-of-pocket cap for patients, which I think has been probably widely discussed and will be tremendously beneficial to people with conditions like cancer, multiple sclerosis, rheumatoid arthritis, where they would have typically reached that phase of the benefit where they have unlimited cost sharing. And of course, the expansion of benefits to lower income people who are sort of at the near poor, near duals, now all people who qualify for the enhanced benefit due to low income will have lower cost sharing and support for their premiums. Another way that the Inflation Reduction Act will reduce costs to the federal government as well as to patients is by selecting the sort of most popular or highest expenditure medicines to the Medicare program, starting with Medicare Part D and ultimately expanding to Medicare Part B, and the federal government will set the prices for those drugs. Right now, there is the pricing consideration is underway. CMS will give their first go at the prices for the 10 selected drugs back to the drug companies in February. Those prices will be announced in the fall, and then will be in effect January 1. The reason this is an issue for drug development is CMS is not choosing the 10 most wasteful drugs of the Medicare program or the 10 drugs with the most egregious prices. It's the 10 drugs that are sort of floating to the top, which is a way to save money for the federal government. It's not necessarily a way to increase patient access to highly efficacious medications. What this does is creates an incentive to either develop drugs that are not intended for elderly and disabled people, or to focus on drugs that are less likely to be selected for price controls. So a couple of ways that could be done. One would be by focusing on large molecules, which are affected by the price controls, but later in their life cycle. The other would be to split development programs up and not pursue additional indications for the same molecule, which again would be likely to increase the sales. So you could be in a position where, well, if you think that one more indication will push you into this realm of being price controlled, then you are better off putting your money into another development program. So again, that creates an incentive to not do the most efficient drug development, right? The most efficient drug development is to just add on additional indications to a highly efficacious and safety proven molecule. And then, the other way that I think drug development will be affected is by the shift of risk for the health plans. The health plans that are offering Part D benefits will now bear more of the responsibility for high-cost patients. When the Part D benefit was put in place, the federal government had a lot of the cost responsibility for high-cost patients because they didn't want plans to have a disincentive to cover those drugs. That spending has grown tremendously faster than the rest of the benefit, due in no small part to the proliferation of new treatments for higher need, high impact conditions such as cancer, such as neurology, and those drugs tend to also bear high price tags. Now that the plans are going to have a lot more responsibility for the risk, I anticipate there's going to be a lot more access restrictions. Just because a drug is covered does not mean that a drug is accessible to a patient. And so with those access restrictions, again, those markets become less attractive. And I think you will see possibly less of an incentive to develop those kinds of drugs as it becomes more and more commercially difficult. And then the final point, and this is kind of tying back to the presentation that Tricia just gave, and then I will cede the floor to Mariana. With the change in risk, it is going to be harder for PDPs to remain profitable in the new environment. So I think we're going to see more lives shifting into those Medicare Advantage plans, which, as Tricia just mentioned, has some benefits to patients, but also gives those Medicare Advantage plans even more leverage for extracting discounts and lower payment rates to doctors, to biopharmaceutical companies. So again, that puts another level of pressure on commercial viability for therapeutics in the Medicare program.
Great, thank you. Dr. Socal?
Well, first of all, thank you so much for having me today. It's a great pleasure to discuss these issues, and also very exciting, to be in the midst of so much change and with the expectations and seeing already the first steps in this, sequence of changes to our Medicare benefit, especially in Part D, already starting to occur. I will piggyback on what Kirsten just said, and first of all, remind ourselves of this context that Kirsten very well already presented. That is, the negotiation program is not coming alone. It's coming as a part of a multi-pronged strategy to curb, drug prices and help with patient affordability. In the Medicare program, it comes together, we're negotiating the top spending drugs. We're also capping beneficiary out-of-pocket cost. This year, this year of 2024, patients who are paying up to $3,300, when that threshold is crossed, they don't need to pay anymore. So that's the very first time that Medicare Part D beneficiaries had this cap, and they can now be more clear of how much they will spend over the year, and they can know that there is a maximum coming up. So that's really important. Not all patients will need that cap. It's estimated that only about 20% of beneficiaries will reach the cap, but still, for those who do, it's a very, very important benefit. Together with this, we know we have copay caps for insulins, which several states already had, and now it's part of the Medicare program for every single beneficiary. And in addition to this, and I'll say it's important for us to remember, there's also a component that is the inflation rebate. And I will explain why, but it's important to know that for drugs that have been already in our market, they already are sold in the United States, they can now, they're free to raise prices over the rate of inflation. But if they do, they may have to pay a percentage of that increase back to Medicare as a penalty for increasing prices. So it's part of a multi-pronged strategy. And within this bigger strategy, we have this drug price negotiation portion, which I find it very, very important. I find it a very significant change in our market. It is the first time that two things are happening. The first thing is that whatever price Medicare comes up with, which is going to be called the maximum fair price for these drugs that are negotiated, this will be publicly known. And today, I can assure you, no patient in the United States knows for real how much their drug is costing to their plan, unless the person is paying out of pocket in cash because they are not covered or their plan doesn't cover the medication. You know, today, nobody really knows how much their plans are paying for their medication. And finally, in Medicare, we will know that. And that number will be available even and known for even, you know, any person in the public. Everybody will know finally how much a drug costs. But in addition to that, the way that the Medicare program is structured today, when we talk about Part D and access to prescription drugs, like Tricia already mentioned, every person, if they're not enrolled in a Medicare Advantage plan, they have to select a Medicare Part D prescription drug plan. And these are various plans, and each plan individually negotiates with drug manufacturers. For the first time, we're going to have one negotiation on behalf of all these lives. And nobody needs to be a very, expert to understand why there's strength in numbers in negotiation. Because manufacturers, when they know they can anticipate a high volume of their drug, they can be more likely to provide a discount. You know, that's the model that places like Walmart use to get a lower price on the goods they sell. You know, anybody wants to sell in Walmart because they know they will be selling more, and then they're more willing to give that discount. Now, a couple more items before we go into greater discussion on this so that we can lay the groundwork to understand what is coming. The negotiation program is selecting now 10 drugs. But these are not just 10 random drugs, like Kirsten said, they are the 10 top spenders. But to hone in how much they matter, these 10 drugs that were selected in 2023, their final price comes up in 2026, these are responsible for over 20% of the spending of the entire Part D program. And mind you, Part D covers more than 2,000 different drugs, you know? So we're talking about 10, we can count on our fingers, and they are responsible for more than 20% of the entire program spending. So, you know, these are important drugs. But in addition to that, there's a reason why these drugs were selected for negotiation. And the reason is actually two reasons. The reasons are these are older drugs. They have been standing and sitting in our market, being commercially available for at least 9 years for small molecules for a conventional drug, or 13 years if we're talking biologics. That's one criterion. And the second criterion is they have not only been for a long time, but also without a competitor. Today, all the structures we have to negotiate prices, prescription drug plans, you know, private insurance plans, everybody, in order to negotiate, we need competition. If the plan doesn't have a generic or a biosimilar, the plan really has their hands tied, because they cannot say no to Humira, for example, because, you know, they couldn't. In 2024, with biosimilars, we can. So these are drugs that should have had competitors coming in the market for a long time, but they haven't because of many different strategies. Maybe the manufacturer put a patent on the drug, maybe the manufacturer had some sort of agreement with the generic, or maybe they litigated against the biosimilar or something. And because of those strategies, the drug has been standing without any competition in our market. So that's why it was important for the government, for the secretary to step in and say, all right, we will negotiate on behalf of Medicare beneficiaries. And in these negotiations, given that competitors are not available, then Medicare is looking at other things like prices of therapeutic alternatives, or how much money came from the public funds to fund for the development of those drugs. So, you know, it is an initiative that has never occurred before in the United States. And I'm very excited to see where it's going to. I anticipate that the benefits for patients will be significant, not only because of the price transparency, but because today, really it's up to the Medicare plan to decide how much the person needs to pay And in certain cases, like insulin, sometimes patients are paying more than the final cost of the drug because of the large rebates that the plans get. So with the transparent price, plans will now have to uncover, have to disclose how much patients are paying out of the actual price. And all the plans will be mandated to cover these drugs. So what Tricia mentioned about, a person not having an option in Medicare Advantage, they cannot, they're stuck with that plan. If the plan doesn't cover, they don't have an option. Today, at least for the 10 negotiated drugs, every single plan, once the maximum fair price comes into effect, will have to cover. So I'll stop here. I'm really happy to tell more about the nitty-gritty of the consequences and what we think can happen. And I'm looking forward to the questions.
Thank you both. I want to start with a question about how the drugs were selected. So in August, CMS announced the first 10 drugs to be negotiated. As Kirsten said, they'll be kind of going back and forth, or they're going to be giving the manufacturers their initial assessment of what the maximum fair price should be in February, and then they'll go back and forth. And then whatever they agree to will be in effect in next year. Then sometime later this year, and I don't know if that time frame is laid out, they will be announcing the next 10 drugs to be negotiated. I think there was a lot of I think everybody agreed that no one had the list right when everybody was trying to predict what the list would be. And on the list at the first 10, there's only one cancer drug there, but there's, expectations that there will be more in the next year. And then after that, they'll look at Part B, which is the infused drugs. So we know that it will affect more cancer drugs coming down the line in the future. But I think one of the reasons why everybody was wrong in their prediction about what the 10 would be is that CMS was using their data on what they're spending, and they're looking at total spend. And Kirsten, you said that maybe they should be looking at the most wasteful, or what was the other that you said that they could be looking at, that maybe they're not looking at using the best criteria, that if they're just looking at total Medicare spend, maybe that's not the best criteria. So would you elaborate on what you think they should be looking at to pick those drugs? And then I'd be interested in Dr. Socal's view on that as well.
Absolutely. And another reason I think all of us got it wrong in our predictions is, CMS hasn't released the data they're looking at. Yeah. The most recent data is older than the data they used. So, look, part of the reason I think the criteria are wrong, and, it's a little bit to the counterpoint about competition. A number of these drugs on this list are in highly competitive therapeutic classes. And if you look at data on the estimated rebates are already in excess of 60% for some of these drugs. They're in classes where there is not a generic competitor, but there are multiple therapeutic options. So these are drugs where the drug company is already giving a big discount. The drug is already, for the most part, on third tier. The federal government is going to set the price, and the drug is still going to be on third tier. So the patient is not going to experience a change in their cost sharing. Now, if the drug is on a coinsurance tier, the patient could see a change in their cost sharing. But I think they're also likely to see an increase in the step edits and prior authorization requirements, because the price setting provision is also being combined with the plans taking on much more risk for the higher cost patients. So this is most certainly going to save the federal government money. It is not clear to me, other than the out-of-pocket cap, that this will save the patient a lot of money if these are already very competitively discounted drugs for access. I would have rather seen, if the drug is already competitively discounted below that 80% of non-FAMP, which is the threshold the federal government is using as the ceiling, that those would be drugs where you'd say, well, the market is working. The plans are doing exactly what the Medicare benefit was set up to do, which is to use their leverage to get discounts from the drug companies. Let's look at the drugs where there aren't the discounts, or there isn't largely third tier access, which would be an indication that there is a lack of competition and ability to secure discounts in exchange for favorable placement.
Okay, Dr. Socal.
So I agree with the facts. I just disagree with the interpretation. And I think this is so important that we have this conversation, because it is a fact that it's the plans that determine how much patients will pay. However, Medicare has a threshold, and the threshold is about $800 a month for a 30-day supply for what is considered, quote, a specialty drug. So if the drug is considered a specialty drug, typically that drug will be covered with a percentage of the drug cost being charged to the beneficiary. So even if the plan was obtaining, 80% discount on an $800 drug per month, so the drug to the plan was much cheaper. When patients pay a co-insurance, they always pay based on the total price without these rebates and all of those price concessions. One of the reasons for that, it's because of timing. So when the patient goes to the pharmacy paid that price. So that's the price that the pharmacy knows. And the plan says the patient has a 20% co-insurance. That money needs to flow back into the supply chain all to the way to the hands of the manufacturer. And only, months later, sometimes it's at the end of the quarter, sometimes at the end of the 6-month period after that transaction was finalized, manufacturers and plans will calculate how much this rebate is, and then they will send the money back to the plan. So this money helps premiums stay low, supposedly, allegedly, that's what's happening. But at the time that all of that rebate came back to the plan, the patient already paid as much as they needed. In co-insurance, whenever you're paying a percentage of the list price, I'll just give the example of Imbruvica. It's a cancer drug that is in the list. I mean, the list price is so high, it's like about, can be as high as $30,000 for a 30-day supply. So imagine you're a patient being charged a 20% co-insurance, which is something very typical. The patient will be having to pay a $6,000 copay, even in the first fill sometimes. So for these drugs, of course, for 20% of the cases, like we said, for patients who cross the threshold, then there will be a relief through that mechanism. But for all other patients, if they need one more pill per month, if they need an increase in dosage per month, if there's a fluctuation in the drug price because of inflation, patients will always pay more, as opposed to what Kirsten said about a tier 3, which is a fixed copay. Maybe the person knows it's a $50 or even $100 copay, but that's a fixed price. And then the person at the very least can know and anticipate, but at least be shielded from these fluctuations. Now, these competitions that occur between these branded drugs like Xarelto and Eliquis, which is the two, anticoagulant drugs in the list, they compete against each other. They have an incentive to give rebates. But again, these rebates, one, do not help patients, and two, they are not publicly known. So one of the positives of this change that now prices will be known is that other drugs in the therapeutic class will have even more incentive to lower their price. And one final thing, and I'll stop, is that the criteria, in my opinion, were so well designed that if the drug is anticipated to have a generic or a biosimilar coming in that period, the drug doesn't get negotiated. So it's a strong incentive for the manufacturer to say, you know what, I'm not going to litigate and hold up this competition because I prefer to negotiate with my competitors than to negotiate with the government and have my price be transparent. Transparency can be really undesirable to both plans and manufacturers because it prevents the plan from pushing the cost to shifting the cost to the beneficiary, which is happening for all of these drugs with rebates.
Thank you. This is just sort of a question about the interpretation of the law. So as someone asked if the Part D cap, I know that the $2,000 cap doesn't go into effect until next year, 2025. Can you clarify what the cap is in 2024?
Sure. The way that the statute is written, I always have the same question, so I'm glad somebody brought it up. There is a threshold for how much the patient pays and how much the total cost of the drug is. So in 2024, patients are paying a maximum of about $3,300, and the total cost is about $8,000. So it's just the threshold is the same, but it's just the breakdown between who's paying what portion. That's what brings up this confusion about the numbers here. And for 2025 onwards, that's when the $2,000 for a patient really kicks in, which is, the number we have been talking about a lot, but it only really kicks in 2025.
Great, thank you. So for the list of drugs that are being negotiated, can plans still implement some of the utilization management practices that we've talked about earlier to limit access to these drugs? I think some advocates are concerned about that, although I do believe there's some protections in the law about that, but can you explain that a little bit?
Yes, so the plans, if a drug has the price set in the maximum fair price program, the plans do have to cover the drug. But coverage, as you know, can include step edits, prior authorizations, having to fail first through a number of other therapies. For an analog, you could look at the 6 protected classes where the drugs are required to be covered. But even within those classes, there are access restrictions. There is still significant discounting to get one less prior authorization or one less step edit. And so, to the point about all the, many of these drugs are already covered. But to the point about now that they're going to have to be covered. So yes, those plans will be sort of forced to put the drugs on formulary. If they aren't already, they will not be getting the rebate dollars. And typically plans use those rebate dollars as Dr. Socal said, either to reduce the premiums or for their own profitability or to offer other benefits to the patients.
But is there expectation that they will do more of these, utilization managements than they're already doing for these drugs that were selected because of their expense?
I believe they will, largely because of the change in risk sharing. So we've gone from the government subsidizing 80% of the spend in that catastrophic coverage reason to the government, the plan now picking up 60% of that. And then you combine that with the out-of-pocket cap. So the plans have lost a lot of their leverage to use cost sharing as a tool to control utilization. So I think they're going to use non-financial tools to control utilization, like step edits, like prior authorizations. You see that a lot in the Medicaid program where the copays are very low and states typically don't turn a person away for not having it. So you'll see strong prior authorizations paired with formulary that essentially covers all the drugs, but some drugs have bureaucratic hurdles.
I would like to comment here that there is what can plans do? What plans can do 3 things. They can charge you more to get the drug you want, like a co-insurance or a higher copay. They can restrict your access through a prior authorization or step therapy requirement, something like that. Or they can exclude the drug. For certain classes in Medicare, like oncology drugs, anti-epileptic medications, etc., then we have a protected class which plans cannot exclude. But 4 drugs on the list were for diabetes. And for diabetes, it is completely fair game for the plans to exclude drugs. And they have been doing it across the board. For insulins, for non-insulin medications, it is a very strong. In fact, I have been seeing data on this, how formulary exclusions have been going up the roof, because of brand-to-brand competition, and plans need to do something to lower spending. So exclusions is a big one. But for the drugs that stay, prior authorization or cost sharing is the way that plans can do. So personally, I think that having the requirement that plans do cover these drugs, when we're talking about drugs outside of oncology, for example, but that are also important for oncology patients, such as these anticoagulants or drugs for heart failure or even for diabetes and other chronic conditions, all of these drugs are more and more. This is a trend that has nothing to do with negotiation. It has already been increasing over time very recently and very fast. Exclusions and utilization controls like prior authorization. So at least we're going to take care of the exclusions. At least your plan cannot take away your insulin anymore or your Xarelto anymore. Maybe they will put a prior authorization in it. But like Tricia mentioned, there are ways that people can contest those decisions. And typically, if they get a denial in the first time, they will get it overturned over time. So what happens when we have an utilization control is really putting a huge time burden on patients, because they have to talk to the provider has to do a time burden. but it is an avenue to get access as opposed to exclusion. When the drug is not in the formulary, it's much harder, if possible, to get it.
And there's been some, I think pretty bipartisan efforts to try to pass some a law limiting prior authorizations, but I think that it's not likely to go anywhere because of the cost, right? It was scored pretty high. I don't remember what the score was, but I think that I don't know where that stands, but I think that it's definitely going to be an uphill battle in the current Congress right now, and with the score that it had. Was that your take on it?
I would agree. And as Dr. Socal just said, instead of the federal government taking on the cost or the plan taking on the cost, it pushes the incidence of the cost onto the patient and onto the provider. So that is a decision to be made, because a patient taking the time to get the prior authorization, does not score. There are ways to make prior authorizations smarter, having longer look back periods. A person should not have to fail every time on the less expensive medicine, or repeatedly fail on the less expensive medicine. We could ask patients to attest that they've already used a therapy, or their physician. So, as we see these prior authorizations and step edits become more common, I think it's really important for advocates and people who depend on medicine to be, if not arguing for limits on prior authorization, at least more clinically relevant prior authorization step edits.
Can I bring I would really like to bring a concept here that I think it's missing in our conversation. Whenever we're talking about Medicare plans, we're talking about it, even in Part D. In this conversation today, we're always talking about the plan, but we're forgetting to mention something very important. When we talk, the plan is designing the formulary, and that the plans are negotiating prices with manufacturers today. Even Medicare Part D plans, most of them, I think Tricia showed really well for the Medicare Advantage space, how they are actually, all these private entities. In the Part D for prescription drugs, all of these plans, most of these plans, they're not directly negotiating. They actually hire a pharmacy benefit manager, which is a PBM, is a very famous entity in our policy discussions today. Because pharmacy benefit managers, they pretty much have all the power and very, very little liability. So the pharmacy benefit managers designs these formularies on behalf of Part D plans. But if the patient, for some reason, cannot afford their insulin or their cancer drug and has to drop out of the treatment, which we know happens frequently, the Kaiser Family Foundation estimates is about 1 in 4 patients either delays or skips doses or cuts doses, because they cannot afford their medication. So for all of these patients, if they have a clinical consequence and they go to the hospital, for example, or they die, or they have some sort of aggravation of their clinical status, there is absolutely no liability. There's no accountability that the plan, the pharmacy benefit manager that designed this whole thing, they have no skin in the game. They will not be penalized. They will not incur higher costs. In Medicare Advantage, the plan is responsible for everything. If the person goes to the hospital, they have to pay for that hospital admission if they cannot take the drug. So we see, more of a continuum across the care of these individuals, whereas in the standalone Part D plans, there's absolute detachment from the clinical outcomes, the clinical utilization. So it is today on the plan's best interest to actually shift costs to patients, to have their premiums low, to have a very nice financial, outlook. But in fact, they have no liability to actually promote patient affordability, patient coverage of the drugs that patients need. And it is that disconnect that generates so much of these problems at the patient level. One example is that these intermediaries, they actually make a profit off of these rebates. They make a profit off of these discounts and these price concessions that they negotiate. So it is on their best favor, on their best interest, to keep covering, more expensive drugs without a generic, for example, rather than having cheaper drugs on the formulary, drugs that are, straightforward priced, and that they cannot provide these revenues for the intermediaries and sometimes for the plan. So, there are distorted incentives there that I think they're not super easy to resolve, but they do have a very clear relationship with the problems we see today at the patient level.
Sounds like you're arguing for Medicare Advantage plans.
Well, they're not without problems. They are all, managed by the same entities. I don't think we have a very clear, good example, and we will know when we know the prices. Perhaps that will help us with transparency to know who the good apples versus the bad apples are. But today we don't have enough information to know.
So I want to get to at least one more question, but hopefully we can address this. So what about the concerns regarding the IRA's impact on treatments for rare indications? Will manufacturers hold back on delivering therapies to the market until broader or additional indications are available? That's what we've heard from some, manufacturers and from industry, is that it's kind of taking away their incentive to pursue additional indications, or maybe that only to pursue indications for where they're going to have a bigger impact and a larger market share, basically, and not pursue the rare indications.
Look, when making a decision on clinical development and determining where to place investors' money or the biopharmaceutical company's own money, it's a two-pronged decision. It's unmet need and it's commercial viability. What's the anticipated revenue? And we've already heard companies saying they're going to make the logical choice. If they only have 9 years anticipated sales on the market before a price control, they're going to go for the biggest indication first. Remember, within that 9 years, it's one thing if they were doing the price controls at 13 years, which is when you would typically expect a generic. Between 9 and 13 years is about half your revenue, just because of the way a growth curve works. So for a large Medicare population, you are cutting a lot of revenue off. So yes, I think that the sequencing of indications is going to be different. The typical sequence, as I think many people know, in cancer and many other conditions, to study in the most severe, often smaller population first, where you're likely to see the most therapeutic benefit, and add on from there. I do think we're also going to see increasing interest in one lone indication for a rare disease where that is commercially viable, because those drugs are carved out of the price setting. So there's no doubt this is going to affect. There is a well-established relationship between anticipated market size and investment in market and R&D.
Dr. Socal, you want to chime in?
I have a more positive outlook on everything. So I think we will continue to see drug development. Like Kristen said, drugs that have one indication and therefore an orphan condition, they will be protected. They will not be negotiated. But, for orphan conditions, the utilization in Medicare will be always so low that even at a high price, these drugs are very, very unlikely to reach the top 10, top 20 spenders. The drugs that are making the cut, like I mentioned, they are responsible for a lot of the spending. And it's very unlikely that a rare disease would be able to provide that, given that the very low number of patients utilizing rare disease treatments, especially in the Medicare program. So I think drug development will continue, and there is already a very strong trend that started many years before this negotiation came into being, and there's already a strong trend towards biologics, towards cell and gene therapies, towards rare and ultra-rare diseases, and I think all of these trends will just continue.
And I think you're right. And I think that's going to mean more expensive drugs. A lot of the incentives that are here discourage investment in large populations, chronic conditions, discourage the entry of biosimilars that the government's already set a low price. So I do agree that drug development will continue. Again, that commercial axis on the decision tree will affect decisions towards more niche drugs, which are often more expensive.
Well, I have more questions to ask you, but we are out of time. It is 1 minute after 1. So I want to thank you both so much for joining us. I really appreciate your time and sharing your expertise. And thank you to everybody for joining us today. We'll send out a link with the replay of the webinar. And we really appreciate your interest in these topics. And Kirsten, Mariana, thank you so much for sharing your expertise. Have a great day.
Thank you both.
Thank you. Bye-bye.